So the first question, in no particular order, how would you explain having a pneumothorax with no pain? This happened to me and was dismissed just being breathless. As Mr. Calcat said this morning, the pain is usually when the pleura is inflamed, and the lung, which usually runs smoothly over it, gets stuck on it as you breathe in and out, and it's called this pain that we call pleurisy, which is just a pain that's worse when you breathe in and out. If the surface of your lung or the surface of your chest wall isn't particularly inflamed, or that maybe the lungs collapse down so far that it's not in contact with very much of the pleural surface, maybe it won't cause that much pain. I mean, this certainly happens. You see people who are a bit more breathless and they're not really sure why, and you do a chest x-ray and sometimes they have a pneumothorax. But it's much more common to have pain. If anybody has an odd increase in breathlessness for no very obvious reason, then I would usually perform a chest x-ray on them just to make sure that they haven't had a pneumothorax, or in fact they haven't got pneumonia, which can also present with few symptoms other than breathlessness. So I think if you do have an unexplained increase in breathlessness, a chest x-ray is usually a good idea. As Annika did also, you can listen to your chest. Get someone to listen to your chest with a stethoscope. That also works for pneumothorax quite often. So that, I mean, it needs evaluation. In medicine, when you do have something that's not typical, it's much more likely to get missed. And so, if you see somebody who's really on their game that day, then it's not a problem. But it's much easier for atypical things to get missed, and like people not being diagnosed with LAM for years. The next question is about pregnancy. And it says, can pregnancy be like a start button on LAM? And the person's written that they don't have any symptoms from LAM. What can I expect after pregnancy, and may the disease accelerate, really, is the question. I think I have seen a reasonable number of people who've become pregnant after they've known they've had LAM, and quite a lot who've obviously had LAM and been pregnant and not known they'd had LAM, but when you look back it was, they must have done. And it's a very variable thing, and what I tell people when we're talking about risks of pregnancy is that there are risks, and we've already said that there's an increased risk of pneumothorax, maybe tenfold during pregnancy compared with the rest of the time when you have LAM. The other things that can happen are, because angiomyolipoma is a similar pathology to LAM in many ways, that's also estrogen responsive and hormone responsive, and angiomyolipoma can change in pregnancy, and you need that monitored. What's less obvious is whether the disease itself accelerates. Does your lung function fall faster? Do you get more cysts? And for some people, that does seem to be the case. It's all fairly anecdotal. Actually, we're just writing a paper with a group at the NIH at the moment, pooling all of our pregnancy experience together with lung function before and after to try and answer some of those questions. And I think my best guess at this is that for some people, there probably is an acceleration in disease during pregnancy. And I've certainly seen patients for whom that seemed to be the case, perhaps not just due to pneumothorax. But there are other women who seem to do pretty okay during pregnancy. And for some people, they might have pneumothorax, but actually it doesn't mean the disease is a lot more active afterwards. And the thing I say to people when they're considering pregnancy is really it is their decision. And if your lung function's good, you can, and if you had a pneumothorax, you could tolerate it. It wouldn't be your dream sort of pregnancy plan, but at the end of it, everybody ends up with a, with a healthy baby in all of the, certainly in all the cases I've looked after in all the literature. It's a decision that, you have to make, weighing up the risks and the benefits. So it's always a tricky area, and many people are diagnosed just when they're thinking of starting a family, and it is an important and difficult question. But LAM is no longer an absolute contraindication to pregnancy, in my view. But again, it's a very individual decision. Good lung function, maybe you've had pneumothorax, but maybe it's been treated, then, that might not be such a risky situation. But you need to talk it through with your doctor. It says here, what is the link between menopause and LAM progression? Is there a drop-off when the menopause starts? Certainly, most women with LAM are diagnosed before the menopause. If you look at the average change in lung function in women before the menopause and after the menopause, for those in old studies not treated with rapamycin before rapamycin was discovered as a treatment for LAM, on average, FEV1, this measure of lung function that we think is important in LAM, falls by about 100 millilitres a year. It falls in everybody as they age, but only by about 20 millilitres a year in a person without lung disease. So if you're before the menopause, the loss of FEV1 is about 100, 120 mils a year. After the menopause, about 40-ish on average. So the disease does tend to slow down. We think that as LAM's an estrogen-driven disease, when your levels of estrogen fall after the menopause, and they don't go down to zero, but you stop making estrogen from your ovaries, but you do make estrogen in fat. You convert testosterone to estrogen using an enzyme called aromatase through a different mechanism from making it in your ovaries. So you've got a little bit of estrogen after the menopause, but not so much. So we think probably this fall in estrogen probably causes the disease to slow down after the menopause. There was a recent study, in fact, of using an aromatase inhibitor, a drug that blocks the production of estrogen outside the ovaries in postmenopausal women LAM. It's currently used for breast cancer, actually. And that study, it was a small study. They didn't quite hit the recruitment targets. But there was a suggestion that the people who took the aromatase inhibitor had lower VEGF-D levels, which we think might be a biomarker for LAM activity. So more work needs to be done, but it looked like blocking even postmenopausal estrogen might be helpful, although the results weren't very clear and more work needs to be done. But certainly the menopause, we usually think for LAM is a good thing. What's not good about the menopause is when people take hormone replacement, which is basically a big dollop of estrogen in a pharmacologic form. And I've certainly seen the disease sort of wake up when people have done that. So that's the reason why we try and prevent people or suggest they don't take estrogen for hormone replacement. So this next one, what's the current thinking on being on transplant list and coming off rapamycin? Is that still the current guidance? Well, it's all very topical this year, isn't it? So most transplant centres will tell patients to stop taking rapamycin when they go onto the active list. So when you, for those of you who don't know, when you go for a transplant assessment, the team will evaluate you. You'll have quite a lot of tests, and then they'll say, yes, this person's suitable for lung transplantation. And if they think, well, we don't need to do it now because they're actually still too good at the moment, we'll wait, then you're on the sort of waiting list. If they say, well, actually, we think we should consider you for a transplant when an organ is available, you go onto the active list. And at that point, most places will stop the person from taking rapamycin. And the reason they do that is quite a few years ago now, I think maybe 10, there was a study which used rapamycin as immunosuppression directly post-lung transplant. And a significant number of those patients the anastomosis, turn away now, those of you who are squeamish, the anastomosis in the trachea, the bit where they sew on the graft lungs to the bottom of your own windpipe, they dehisced, which is medical term for fell apart, which was a catastrophic occurrence, and the patients died as a consequence of that. And it was because rapamycin inhibits wound healing. Now, this was 6 weeks post-transplant in patients taking a high dose of rapamycin and other things for immunosuppression post-transplant. It was not somebody taking low-dose rapamycin 1 milligram a day because they have LAM and no other drugs. So at the moment, the situation is people have to stop taking rapamycin when they go onto the active transplant list. A lot of people are understandably nervous about that. If people's lung function's falling progressively, they go onto rapamycin, everything stabilizes, but they still end up needing a transplant at some point in the future. And then they say, well, you've got to come off this drug that's delayed that for many years. They think, well, we know the disease reactivates when you stop taking the drug. That sounds pretty dangerous. So they're understandably reluctant to do that. And I said it's topical because we've had a few questions about this in the UK. And also a couple of the transplant centres in America are thinking, well, actually, it's probably safe to do, providing we stop the rapamycin on the day that you have your transplant. And it will all be gone in a couple of weeks. And by the point when all the problems occurred, the drug will be long gone. And so people think that it's probably a safer approach for patients doing that. Currently, we don't have any really good evidence for that, and there's a big debate going on between transplant centres and LAM doctors around the place. Frank McCormack's involved. There's a guy called Dan Dilling who runs one of the transplant programs in Chicago and is a LAM doctor who I think favours keeping patients on the drug. And so we're trying to get some evidence together to see if that's a safe strategy, really. So at the moment, yes, people need to stop. But actually, I'm currently talking about somebody with the Newcastle service at the moment. And we're we're batting a few ideas around between us, I think, is probably the best way to describe that. Any questions about that? Have I covered what the question was about? Okay. So the next question, can someone with LAM be an organ donor? And it says in brackets, obviously only healthy organs. So I think, again, we don't really know the answer to that question. So one of the issues here is that the LAM cells in your lungs and your kidneys are a clone, which means they all arose from one identical cell type. And we know that because the mutation's the same in every bit of LAM that ever gets sampled around a single person. So what's happened is one cell's developed a TSC2 mutation. That's activated mTOR, conferred a proliferative advantage and a metastatic advantage. The cells disseminated around the body and set up shop in different places in the lungs, in the kidneys to make these tumours, and in the lymphatic tissue. So those cells got there by swimming through the lymphatics in the bloodstream. And of course, if you're thinking, well, maybe they're in other organs too, and if someone has a transplant, will they get LAM because you're transplanting LAM cells? And that sort of is possible. Although, as far as I know, there's no reports of that ever happening. So that would be the concern for LAM donors. There are certain sites where the blood doesn't get to, and they're called immunologically privileged. So that, like cornea, for example. So maybe that would work. But I suspect the answer to can someone with LAM be an organ donor would be probably not. On general safety grounds, I would say. I mean, it would probably be okay, I would have thought, but I suspect that people would get would probably not allow that. Oh dear, I wish Mr. Calcat was here. What's the best thing to do if you're experiencing a localized pneumothorax? Rest or carry on as normal? Is exercising okay? Does exercise increase the likelihood of a cyst rupturing or leaking? So what do people do when they get a localized pneumothorax normally? Probably you get a bit of pain, don't you? I suspect most people end up doing a little bit less. I think if you're doing a lot of exercise where you're going to be breathing more deeply, or if you're doing lifting or some sort of weight-bearing exercise where you're probably straining, holding your breath, that sort of thing, it will increase the pressure across the surface of the lung, and it might make pneumothorax more likely, and it may well cause it to get worse or maybe not settle down quite as quickly. So I would have probably thought when you have the pain, I probably wouldn't do anything too strenuous. I wouldn't go to bed for 3 months, but I'd probably would do a little bit less, and certainly anything that made the pain worse, I'd avoid doing. They usually settle down in a couple of weeks or so. Is that people's experience? I'm sort of saying this. I've never had one myself, and I'm sure. Yeah, I would have thought it would be sensible to avoid doing most of those things. Is there a racial bias to LAM? Not as far as we know. I did an epidemiological study a few years ago, which wasn't really powered to answer this question directly, but we did record the ethnic origin of everybody with LAM in the survey of the UK. And then we compared the distribution of those ethnic groups with the normal distribution of different ethnic groups in the UK, and we didn't find any significant differences. It wasn't higher or lower in Asian people or any of this sort of thing. It seemed to be pretty, the percentage of people with LAM was pretty similar for the ethnic group to the normal distribution in the country. We certainly know about LAM occurring in most other countries. Most places have got LAM organisations and patients. We don't know much about Africa and the prevalence of LAM in black Africans. There aren't many LAM services in Africa, but certainly for people who've migrated to the UK, we do see LAM in that group. Maybe it's poorer sunlight when they get to UK, I don't know, but less vitamin D. But it does seem to be, there doesn't seem to be a racial bias as far as we know. The last question is, says that this person has chemical intolerances to things like fabric conditioners and can't get close to anybody who used it without being ill. And it started after the person was diagnosed with LAM. And is there a relationship? Well, not that I know of. Has anybody else noticed allergies or intolerances to things after they've been diagnosed with LAM? I don't think that these would be related at all.
Does it not make sense that you're breathing in chemicals and not
do you mean if you're breathing?
Because my lungs have got cysts, I feel much better if I'm breathing fresh air. And if I'm breathing into somebody's chemicals, then I'm not getting the air I need.
So yeah, I mean you're still getting probably the same amount of oxygen because the chemicals are dissolved in it. So you probably get the same amount of oxygen in. The important thing that maybe at the root of this, I guess, is that if there are things, it might not be a shortage of oxygen, but if there are things that your airways are sensitive to and you breathe them in, they might become twitchy, become narrowed, and you might be able to ventilate your lungs less. So if you look, for example, at levels of pollution and number of asthma attacks, then on days when there's more pollution or more ozone or more pollen, then there are more asthma attacks on those days. And that's because things that people breathe in, and whatever it is, ozone, little particulate bits of carbon, these PM10s, these particles that form pollution, they irritate the airways, and they just narrow. Not always an awful lot, but enough to cause increasing symptoms maybe. So it could be something like that, if the airways are sensitive to something. And a lot of people don't get on with things that are strong fumes, odours, perfume sprays, things like that, in the same way that they don't like, say, cold damp conditions, because that'll make them tight-chested. So it may be that the airways are reacting a little bit. That would be my guess. Okay, so there aren't any more written questions. If there's any more spoken ones that you want to come up with.
Just a quick one. I know I've asked this before, but I don't know if the situation has changed at all. But are you interested in donations of lamb tissue at death?
If we can, any lamb tissue is very helpful to us, basically. And so we're always trying to get lamb tissue. When someone dies, it's sometimes logistically very difficult to get the tissue.
That's why I was asking, because if you don't set it up beforehand, there's no way it's going to happen.
That is difficult, because I mean we have had a few people who've and families who've wanted to donate, and logistically with coroners and all the other things are happening around then, it can be really difficult to sort out, and in fact usually doesn't work out in the end, actually.
So there's no way to do forward planning to ease that?
We haven't a mechanism in place for that, no.